I would like to present Dr. Patrick Campbell. Dr. Patrick Campbell is an oncologist, a histiospecialist, and the Associate Chief Medical Information Officer at St. Jude's Children's Research Hospital. And now I'm going to stop sharing my screen so that Patrick can start sharing his presentation.
Great. Thank you very much. Can you see my screen now?
Mhm.
Great. Okay.
Thank you.
So I'm really happy to be here. Thanks so much for inviting me. So as was just mentioned, I'm a physician at St. Jude Children's Research Hospital. I'm in the leukemia lymphoma group, and my patient population that I see is almost all children with histiocytic disorders. I also, for the past almost 12 years, have been the Associate Chief Medical Information Officer. And in that role, I think probably more than is healthy, I think a lot about medical records. I think about record keeping around patients, around clinical trials, and other things. I really like being able to come here and speak to you on the topics we're going to touch on today because I don't have many opportunities to talk to patients and families about these issues. And I think they're really important for people to understand. So I hope you get something out of it. Please, if you have questions, put them in the chat and I will try to get to them. And with that, just moving on. So really sort of short agenda. I'm going to talk some about medical records and how that relates to patients and families who are undergoing care for complex diseases. I also want to talk some about clinical trials with a focus on the consent to clinical trials. And because it is becoming such a key issue these days, I want to spend some time discussing AI. That's going to be scattered sort of in a couple places throughout the talk. I am not an expert on AI. I play with it. I use it some in my clinical setting. And so as was mentioned at the beginning, don't take everything I say, at face value. If you have questions, talk to your teams, put the question in AI, see what it says. Now, I'm joking about that, but we're sort of going to sort of kick off now. And as I said, I want to start talking about electronic health records. And I think this is a really interesting area these days. Historically, when I was in training in medical school, we were using paper medical records. Medical records had this almost mystical quality to them. They were stored down in the HIMSS department, usually in the basement of a hospital. A lot of them were dusty. They contained vast amounts of information that was hard to access and then also very confusing to understand. But as technology has changed, as almost every hospital has adopted an electronic health record, and also then with regulatory changes, EHRs are becoming much more readily available, which in a lot of ways is good, but it can cause a lot of confusion, especially for patients and families. And so I want to focus on that aspect of electronic health records. And so electronic records, as opposed to the paper forms, they really are here to stay. I don't see any hospital, despite lots of complaints from doctors and other clinicians, saying they're going to go back to paper. There are lots of benefits to electronic health records, and I have some of them spelled out here. One of the P's in HIPAA, which everyone, gets, information at HIPAA every time they walk into a doctor's office. One of the P's is portable, and that really focuses on electronic health records. In the past, a paper record, if a patient went from, the inpatient floor down to diagnostic imaging or the OR, paper charts, very often racks full of them, had to follow the patient as they went. If they went to the infusion center, for the pharmacist to know what they're supposed to do, the paper chart had to follow the patient. If doctors wanted to finish up charting at home, they had to take home a paper chart, things which are not good ideas. So the electronic versions are very clearly portable. And as we have seen with portals, they also are portable in the sense now that patients can see their records to a large extent, and they can share their records with other doctors and family members. Electronic records, as opposed to the paper variety, are secured with backups, typically in one or two locations, on-site, off-site, in the cloud. And so that is another big advantage. They are searchable. In the past, if I wanted to know, what a patient's lowest hemoglobin was, their worst anemia ever, it would take sometimes days of thumbing through a chart to find all the records. But now I can find that answer in a couple seconds. I can find out when they last received a specific medication very, very easily. All that searchability, all that sort of clear data also makes medical records in the electronic form great for reporting, great for research. And then finally, this is an incredible platform for innovation. All of these tools being developed now for predictive analytics, which really these are just tools that let doctors and hospitals do things like predict which patients are at risk for developing sepsis, so risk for needing ICU attention soon, to sort of allow us to pay more attention to certain patients. Lots of other forms of predictive analytics, which are way outside the scope of this hour. And then also, as we have been starting to see, AI, which is sort of getting into every piece of our lives these days, also for better or worse, is changing how we interact with and how we add data to the medical record. And so I have that in the benefit. I think some people might argue that's also in the risk side. On the risk side, definitely one of the things we hear about, I'm not sure how many of the people on the call pay attention to the pit, but that's a very sort of true to life example of what can happen with electronic medical records and ransomware, cybersecurity events, where suddenly you are thrown back into a paper world, often in a hospital with people who have never charted in a paper medical record. It's easy to write notes in medical records. It's easy to write notes which are very long and complex and sometimes difficult to understand. Copy paste is used way too much, in my opinion. I have on here, in my opinion, and as will come out later in this talk, is it is really great that patients have the ability to see their records now very quickly. There are some doctors think that that is a little bit too easy nowadays. But I have it in the risk side because with that easy sharing of medical records with patient families comes sometimes a lot of anxiety and a lot of confusion. And hopefully during this hour, we're going to approach some of the ways that families can maybe avoid some of those. And then another thing just on the risk side is that medical records were sort of rolled out on computers with this thought that it would make doctors so much more efficient, make the records so much cleaner, really improve medical care. Despite all these promises, that really hasn't been seen so much, is that we still have a lot of the same risks. There are a lot of advantages, a lot of tools that help us avoid risks in some ways. But efficiency really isn't any better. We just spend our time working on computers instead of notebooks. So as it comes to patients and families and access to the medical record, the biggest change in this country has been the 21st Century Cures Act. This is something that I don't know how many people on the call are familiar with the 21st Century Cures Act by name, and especially with the information blocking rules within this act. But I think that most people have experienced the impact of this. And at a very high level, the information blocking rules, they were put in place, and this is a quote from the act itself. It's to improve the quality and accessibility of information that Americans need to make informed healthcare decisions. That statement is very true, and that statement is very hard to argue with. The basis of this has a very, very good rationale for it. The 21st Century Cures Act, it was signed into law back in 2016, but it took a very long time for it to sort of reach patients. So it wasn't until 2020 that the information blocking rule was finally published, and not till 2021 that it became active. And then finally in 2023, there's started to be some enforcement of it. A couple things. One is this is a moving target. current administration is looking at some changes to this, so what it will look like next year is not exactly sure. Um, but at the end of the day, what the information blocking rule is saying is that a patient medical record really belongs to the patient. It's your information and you should have access to it. And it lays out, while it takes several hundreds of pages of the act and explanatory comments and discussion, patients should be able to view any aspect of their medical record without delay. So that includes access to clinical notes, lab results, pathology reports, imaging results. How exactly that happens, while it's a very sort of straightforward comment, there are a lot of factors that impact what exactly a patient is able to see and how they're able to see it. So hospitals are required to release records. They are not required to release records directly to the EHR portal. It just says they have to be given access. If they want, a patient can ask for the records. They can send them out to HIMSS and hand them a foot-thick stack of paper documents. That also meets the rule. It's not the way any hospital wants to do it. And most hospitals realize that putting information in a electronic medical record portal that is visible to the patient is by far the easiest way to meet the requirements of this. And then there are other factors. So some states had concerns about elements of the blocking rules, and they wrote their own laws that tried to adjust some of it. It's only been a couple states that I know of to date, and I don't know that any of those have really been tested. Individual hospitals have put policies in place about what records get released and how they get released. EHR functionality, whether a hospital is on Cerner or Epic or some other medical record, will affect how this gets presented to patients. And then also one area in my field, in pediatrics, which is very important, is adolescent patients. And different states have different rules around what information adolescents are able to keep personal and not include parents in decision making or show information to their parents. And so when patients reach 14 or 16, potentially there will be some changes in what information parents can see unless their children who are giving them access to the chart. And then finally, individual clinicians' practice can change this. In most medical record systems, a doctor has the ability to say, no, don't share this information yet. It's not always easy to do, it's not always clean to do, but that can affect sometimes what patients can see in their portal. So at St. Jude, we participated in a multi-center study. This involved St. Jude Children's Research Hospital, Boston Children's Hospital, and Yale Cancer Center. And we were looking at the immediate impact to medical records and the results on the part of pediatric cancer patients, which included histiocytosis patients, adolescent and young adult cancer patients, and then the parents of those pediatric cancer patients. And then finally, also on the healthcare providers. And this was done, it was a lot of structured interviews, thousands of pages of interview documents. So these are just two very high level quotes, but I think they sort of give a sense as to what the patients and their parents were thinking. So the top quote is from a parent: I like to have things very controlled in my life. And so with this disease where literally I cannot do anything, having to the EHR helps me gain that control back. And then from a teenage patient, sometimes if things are released and you don't know what's going on, it can seem scarier than it really is. But generally, I think the benefits outweigh the costs. And within this study, we tried to sort of come up with themes of what we are seeing in responses from different groups. And the key overriding common themes that we saw was, one, patients, parents, doctors all felt that access to the medical record increased patient empowerment and how much they were engaged in healthcare. But at the same time, on the risk side of this, is there definitely was heightened anxiety especially when there are sensitive results, patients getting pathology reports from a biopsy or having a MRI scan looking for relapse disease, is that there is a lot of anxiety about knowing that these results are on your phone or on your computer and you have access to them. In some ways, the portal has changed how doctors and patients have communicated with each other. I think for the most part, positive changes, but also in some ways, it's caused some doctors to feel that they are getting pulled in too many different ways at once with questions. And then the other overwhelming common theme was that across all groups interviewed, there was a need for more improvement to EHR portals and how they delivered information and what sort of limitations could be put on and check could be put on that delivery. So while most people, like I say, saw that there were clear positives, there also are some negatives and a lot of things you have to think about when you have access to your medical record or your child's medical record. This could be a 5 hour long talk in itself, this one slide, but sort of some tips for managing portal access. And I will say is that there is a lot of information online. A lot of hospitals have, you know, documents and even people whose job it is to help patients navigate the portal. So look, this is the bottom bullet points there, but look at local resources and see what's available to you. Is that it will depend on where you are, what medical record system is being used as to what options you have for modifying what you see. Across the board, though, any application that you have to access, if you're on an Epic system and have MyChart on your phone, MyChart typically gets installed with lots of notifications, and those notifications can be very hard to ignore. It's Pavlov's dog type reaction. Your phone buzzes and you look. And so one of the key things to start limiting anxiety oftentimes is to modify notifications. Sometimes this is really complicated. There are dozens of different options for how to notify it. But I think some of the key ones and some things that some places, including St. Jude, have put in place from the start is defaulting for something that is a daily notification rather than instant access. So at the end of every day, once you're home, you may get a notification saying there are results or new notes from the previous day. It doesn't mean you can't see them before them, but your phone won't buzz when you're stopped at a traffic light and draw your attention to the fact that there is some result you've been waiting for, some result you're nervous for. Some people are much less immediately tied into email. So very often you can have these alerts pushed to your email or get sent to your email rather than a push notification to your phone. And so that also is often a much more controlled way of interacting with the medical record is you can go in, you can look at your email, and you can access your medical record when you see the results. And then also talking with your care team. And this is something that I really try to impress upon other doctors, other providers, nurses at St. Jude, is to really talk to patients carefully. If you are sending the patient over for a scan or if they're going for biopsy, let them know what your concerns are about results before the procedure and also when the results may come back. And then finally, when best to or how best to contact the care team if you see the results and you have questions, or if you know the results are back, but you don't want to look on your own. And so if you aren't having that information presented automatically to you, talk to your care teams and ask those questions. So another thing that has come up, and I see this in clinic more and more every month, is patients using AI to help them understand their medical record. And AI is fascinating. No matter how technical I am in my daily life, it still surprises me how impressive it is at some times. But AI is not perfect. And there are two key concepts that I think about whenever I'm thinking about AI. One of them is the very professional sounding garbage in, garbage out. So all that is saying is that AI works on the data it was fed. And if you feed a MRI report into AI and ask for an interpretation, the interpretation can be no better than the MRI result itself. And one thing that we have shown repeatedly at St. Jude, as I mentioned, paper medical records aren't great. Electronic medical records give doctors the ability to copy paste and to add huge amounts of information. And a lot of times, notes, no matter how good doctors are trying to be, have errors in them. And AI will pick up on those errors and sometimes amplify those errors. And so if you're looking at something generated by AI and it doesn't make sense, or you're just looking at a note yourself and it doesn't make sense, you think there's some error in it, ask your care team because it could be that you actually are pointing out. And I've had multiple patients point out things that I've included in a note or has been included in the chart that isn't correct. And it is something that is, I think a very important role of the patients if they are going to be looking at their medical record is to question things that don't seem right. The other concept that I really like to focus on when I'm thinking about AI and use of AI and looking at how we use AI is the whole idea of a human in the loop. And within the hospital, this is a very key thing. We have a rule that we are not going to utilize any AI tool within our medical record that does not have a human in the loop, which means that AI can generate as much information as it wants, but that information does not go into a medical record and does not play a role in patient care until it has been reviewed, edited, and signed off on by a credentialed provider. And so that works great in a hospital when the people using AI are those providers themselves. But it's more challenging if you're looking at a MRI result at home, you use AI and it spits something out. And that's where I say is that if something doesn't seem right, ask, is use your team as the human in the loop. So if you see something that's not right, ask. Another thing I'll say is that a lot of EHR systems are beginning to introduce AI tools for patient-facing information, for after visit summaries that get sent to patients, or translating results into more patient-friendly language. And so some of this in current state is very often someone copy pasting from their medical record into a AI tool. It is starting to be something that you may actually start encountering automatically within the patient portal. And then the final sort of tip as far as using AI is be careful with your personal information. HIPAA is a very powerful tool that secures patient information. HIPAA doesn't take effect if you're sharing your own information. If you're posting your information online, in social media, or into an AI engine, HIPAA is out the window if it's your own information. And so I always think about with AI is, would I want to share this information with Google, with Amazon, with Microsoft, with Apple, whichever large company I'm working with the AI engine? And a lot of information, no. I mean, it may not be the most personal information, but it's just not something that I want out on the internet. And by and large, AI algorithms are using information entered by individuals to train their algorithm. And so what you put in there is becoming part of their property and they are using it. So if you do want to use AI to help you understand results, notes, any other part of your medical record, I already mentioned don't use personal identifiers. Another tip is if you have additional clinical details. So the example I have posted here this is actually a made-up patient. So no PHI on this page at all, but it is a MRI result for a patient with LCH, and they are being followed with MRI brain after therapy. And you can paste the MRI result in there, but if you then also include other information about prior therapy, symptoms that your child or you may be having, that can help sort of give you a more personally appropriate reading. And then one thing that I encourage my patients to do is if they are going to use AI, don't just ask for it to suggest or for it to translate it. So I said, translate my MRI result into patient appropriate language. And please suggest follow-up questions I may want to ask my doctor at the next appointment. And I think that last part is really not just giving you the answer to it, but letting AI help you think about how you can discuss this with your care team. And there's a lot of pages here. But let's just say that this query worked very well for this fake patient. Oh, I already had that there. Sorry, this is a duplicate here. So a just brief summary of what came out of here. So one, it said, why was this MRI performed? It got that from the note that the doctor put in requesting the MRI. What is the main concern from the finding? And it comments right here that, there is a new abnormal tissue growth coming out of the bottom of the pituitary gland. Gives a whole lot. The radiologist is concerned this could be LCH coming back in this area. Once again, if you're stopped at a traffic light driving your car, you may not want to see this result at that time. So this is why I say it's important not only to think about when you're going to look at the portal, but when you might want to ask AI to interpret it for you. It also provides what it considers reassuring findings. The rest of the brain looks normal. The areas of the brain that involve vision, which are near this area, near this tumor, look normal. The pituitary stalk looks fine. So all these things that are reassuring, and also some unrelated findings that it calls out, and then has a really nice list of questions to ask the doctor. So there's this new mass of tissue. Do we need a biopsy? How urgently do we follow up? Could this affect hormone? Could this affect vision? If this is LCH, what are possible treatment approaches? So it goes on and on and on. What symptoms should prompt us to call before the next scheduled appointment? So I think that this really is one of the really powerful tools for patients is not just tell me what this said, but tell me what this says and what questions I can ask. And then, of course, it ends up this time I was using Claude, which I was able to use because there was no PHI in this search. And, a lot of these AI engines, they are very polite. They have great bedside manner. So I'm so sorry you and your family are navigating this. Please don't hesitate to ask your doctors to walk through this with you step by step. And so really, sort of calling out the fact that this is AI and just a nice reminder of needing to discuss this with your medical team. So I do want to move on now. We have 30 minutes left to talk about medical research and informed consents. And this is a topic that is so important in the histiocytosis community. And when I think about histiocytosis, where we have been, where we are now, where we will be in the future, research is such a key part to that. So all of the histiocytic disorders are rare diseases. And with that, there really aren't enough patients to always learn what the best therapy is just by observing what people have done. You really need a structured way of treating a lot of patients the same way and looking at the results the same way, and then following those patients to see how many of them got into remission, how many of them relapsed, how many of them had long-term survival without disease, and also what type of complications do they have with therapy. These are all critical things. There have been such incredible research studies done on histiocytic disorders. This figure here is from a paper looking at, this officially was on the LCH3 trial, and this was published back in 2013, but it compares the overall survival of patients treated on LCH3 with high-risk disease, which was 84% at this time, But you compare that to LCH1, LCH2, so the two prior international trials, you can see this really incredible increase in survival. One, LCH1 and LCH2, things we learned from those and from other clinical trials helped us design the therapy for LCH3 and led in a large part to this incredible improvement in survival. And this is one example out of dozens that we could point to of ways that with LCH, with Erdheim-Chester disease, with other histiocytic disorders, clinical trials have impacted the survival of patients, the toxicity that patients do, how we monitor patients and how we treat them. There are other trials that, we've recently finished up looking at using clofarabine for relapsed histiocytic disorders. There's a trial that is still, I don't think they're enrolling anymore, but still treating patients, comparing the LCH3 frontline therapy with vinblastine and prednisone to cytarabine as frontline. So very different approach to managing. Both of them sound like they work, and trying so we can figure out if one is better than the other. And there are so many new trials coming out with targeted therapies. As we've learned about the mutations in the tumor cells that drive histiocytic disorders, we also are learning about treatments that target those mutations and may be very good approaches to therapy. And so that is a huge area of increasing research. A lot of times a clinical trial is available, but unfortunately one is not always available, or there may be one available for some reason you or your child does not qualify to be enrolled on that. And so there are important things. First of all, being involved in clinical research is voluntary. There could be one available, but you just don't think it's the right thing for you. And it's important to understand that there is very good therapy available, even if you are not enrolled on a study, even if you are being treated at a center that doesn't have a specific study open. Is that typically the trials for LCH, they involve treatments that are based on previous therapy or involve medications which may be available off study. It won't be exactly the same if you're not on trial, but you can get very good therapy outside of clinical trials. And then also for people who want to be enrolled in a trial in order to contribute to our knowledge in our community, that is, I think, one of the biggest potential gains from being on a study is how you can contribute back and sort of pass things forward to the next generation of patients. There are other options other than being on a therapeutic clinical trial. There are disease registries that capture patient information, diagnosis information, genetics, treatment, and outcome results, and can be used for sort of retrospectively going back and looking and seeing, okay, for this cohort of patients that were somewhat similar, what treatments worked better, or what treatments caused more side effects. There are biology studies, so looking at tissue from pathology specimens to try to understand more about what is causing these histiocytic disorders. And related to biology studies, there also are tissue banks. So, there is a tissue bank that has been established at Texas Children's Hospital and is part of the North American Consortium for Histiocytosis. And there are samples being collected there from patients with different histiocytic disorders from around the country. And when tissue goes in there, we don't know what studies we are going to do on them, but it is available in the future if there are new studies we need to do to try to understand more about diseases and the best therapies. And so even if you are not taking part in a therapeutic trial, it really is worth your time to talk to your treatment team and find out other ways that you might contribute to improving knowledge of these disorders and their treatments. So with almost every research study comes an informed consent. And at St. Jude, somewhere upwards of 95% of patients are enrolled on at least one clinical trial. So it's something that I think about a huge amount at St. Jude. Tips for sort of getting involved in a clinical trial and taking part in an informed consent discussion. First off, these are discussions. It should be a back and forth, listening to the care team, the research team, and asking questions. And with that, most important thing is plan ahead. Is sometimes that is not much more than making sure you're bringing someone to support you, an adult family member, a friend, someone who can sort of help you sort of think about questions and, just sort of be there to listen and take notes on things. Think about what information is important to you, and we'll talk a lot about that. Um, the information that is considered really important to patients, most of it by regulatory standards and ethical standards are required to be in consent documents. So things like the purpose of the study, what is the information people are trying to learn? What are the potential benefits to being on this study and getting this treatment? What are the short and long-term risks that are being seen or being considered as possible for patients on this study? How long am I on the study? What other options are available is, I think, a very key question is, if I decide this isn't the therapy for me, what are other things you would treat me with, and what are the pros and cons of that therapy? Um, what are details about the treatments? One thing that comes up often is I can give you very similar treatment not on the study. If you're on this study, you have to be back in my clinic once a week for the next 2 years and have a whole lot of testing. As opposed to if you're not on the study, it's once a month or once every 2 months. And so that's an exaggeration of what it is. But sometimes being on the study while you're contributing, it also is a time constraint and can be difficult to follow through on all the required testing. And then also with every research study, while research studies also are held very, strictly to privacy rules, one of the questions is who might see the data and what information would be included in the data that goes along with the study. HIPAA is involved in medical records. Research data is often de-identified, meaning that there is not a patient name in there, but there still is some risk. And so understanding what those risks are is important. So I'm at St. Jude. St. Jude, like I said, we do a lot of clinical trials here. There's a lot of information online. This link here that the QR code also points to goes to a public-facing St. Jude website that has a whole lot of information about clinical trials. Actually, I did not look at it before I made these slides and before I used AI, which I'll show on the next screen. The data on here, actually, in going through this more closely as I was preparing for this, is really good data. And if you have questions, if you're preparing to enroll or you're thinking about things with clinical trials, this is one place you can go with good information. And it is, for the most part, not specific to St. Jude, not specific to our clinical trials, is much more just sort of general information for anyone who is considering taking part in a clinical trial. So I did this with MRI results, and I also wondered how good would AI be at helping me understand a consent. And so some general rules, once again, is avoid identifying information. You should not need to put in your name, your medical record number, your date of birth when you're asking AI a question, and don't if you have any way of avoiding it. And then also, like with the MRI results, any additional clinical details you can do. If you're like, trying to get some information about a clinical trial or about possible therapies, the more information you can give specifics about your own disease, the more customized the answer will be. And then I put a question by this bottom bullet point. Consider pasting in the actual consent document if you want to get a really specific response. If you have the consent document in hand, which by the time you have finished the consent, you should. That's one of the requirements that patients are given a copy of the consent. I put a question mark next to it because I think that a lot of people who run clinical trials would say, yeah, we'd rather you not put that in a public-facing AI search engine. And so I'm not going to tell you you should do that, but I'm also going to tell you is that your research team can't actually stop you from doing it. If you have the document, they can ask nicely. Um, but I think that that's a relatively low risk thing, even from a research perspective. Um, so similar to what I did with the MRI AI query, um, and this is just a general sort of my approach to any query for AI, is the first thing I do is I tell the search engine who the search engine is. So I tell, in this case, this is Copilot, so the Microsoft AI engine. And I tell Copilot that it is a physician and a clinical researcher with expertise in Langerhans cell histiocytosis. And so I immediately sort of give it a role and give it an identity. And that sometimes will affect what results you get into. Also on this screen, so this one is in a secure St. Jude environment. There's this green check mark and a shield up at the top. Web search is off. I'm not allowed to change that. And so in this search engine specifically, I can paste any PHI, any research information, and it does not go out to the web. It stays securely within the St. Jude environment and doesn't go out to train. Most people don't have access to this type, so you won't see this green check mark. And the whole web search, as soon as it searches the web with your query, your information is getting posted out to Google or wherever else it's going. But what I asked this search engine, I said, my doctor is going to consent me for a new clinical research trial of Langerhans cell histiocytosis. What are some good questions to ask during the consent process? So the consent discussion will always happen. And when you think about being prepared walking into that, what can you do and how can I help that? And I'd say, once again, AI did a really good job and way, way too much detail. I'm happy. I don't know if it's automatically shared. I know we're recording this. Um, but I'm happy for anyone to go through and look at this in any detail. But clear things. A lot of these are things that I discussed are already required, but ask about the purpose of the study. Ask about how the trial works. So what phase is this, which gets into details of clinical research, which is a little bit beyond this, but is it a phase 1, phase 2, or phase 3? How am I being treated? Is it IV chemo? Is it oral? How often is that being done? What is the duration? Is this a placebo trial where half of the patients get a medication that won't work at all? That is rare in LCH studies, but potentially could happen. Asking about risks and safety and how they are monitoring. Um, and, okay, sorry, there's some issues with my slides here. Ask about the potential benefits I talked about. Ask about alternative therapies. Um, Ask about impact on daily life, not just from side effects, but from time spent. Do you need to be near the treatment center? I have patients at St. Jude who are from other states, other parts of the world. And if I enroll them on a clinical trial, that means they have to live near Memphis for a year or two, which most people aren't able to do. Um, Ask about follow-up, ask about how they're monitored during follow-up. And then logistics and costs. For the most part, patients aren't expected to pay for research studies, but they are usually paying for part of their care that takes place during the research study. And so understanding what that will mean, what will insurance cover if you have to travel, does the study cover the travel? There are some studies that will give, usually it's a nominal amount, but you'll get a Starbucks gift card or an Amazon gift card when you go for a follow-up study, things like that. Privacy is key. And then also asking about leaving the study. And so this is something that is really, really important, something I stress with every one of my patients and families when we are doing consent, is that the consent document, the consent process is in a lot of ways the start of the discussion. And patients and families can agree to be on a clinical trial, but that agreement lasts as long as they continue to agree. And if at any point in time, a patient or a family member, a consenting parent, feels that the treatment is not right or they want to try something different, they can let the study team know that they want to come off study and they cannot be made to stay on it. This is a voluntary act. So if you decide to withdraw, what are the next steps? What happens? Can you get standard therapy after you withdraw? And then also, this last bullet point, is there a situation where the research team might stop participation? And the answer to that is pretty much always yes. With any clinical trial, there is a question that's trying to be asked. We do not know all the potential risks or all the potential benefits. And if we realize that patients are having lots of side effects, a study may stop, or we may pull a patient off a study because of side effects. Or if there is some new paper that's published that gives some much, much better option for treatment, at that point, it really isn't ethical to continue doing this study. And so a study in its entirety may close halfway through. But it's important to understand what the options are if that happens. LCH specific, and if you include your own personal information, I have relapsed LCH in these organs, I had this treatment before, then AI can very often give information. This specifically, I didn't ask it about targeted therapy, but this AI engine gave lots of information about targeted therapy and trials aimed at specific mutations. And then, as always, communication is important, and asking your team, once you enroll in a clinical trial, you usually have your doctor who's giving you the chemotherapy and that care team. There also is an entire research team usually. And so if you have questions, who do you reach out to and how do you get more information? And so with that, I'll stop. We have about 10 minutes. I hope there are questions. I hope people found this helpful. And on this question screen, I did put, like I say, I'm not trying to sell St. Jude resources. I don't get anything if people click on these links. But just as one resource I know that has been pretty well vetted and has good information. And so thank you very much.
Thank you so much. I'm just gonna wait just a second to see if anybody has any lingering questions, and then if you do think of something that you didn't present in the chat here, you can always send it to info@histio.org, and we'll try to reach out back to you. I'm talking to Dr. Campbell. Uh, there was something actually that I thought of when you were talking about um, the EHR portals, uh, and that is of like previous records from prior to um, when the act was enacted in around
Mhm.
2020, I think you said it was in 2021. My wife, she's hydrocephalus, and so she sees a neurosurgeon for that. And she was switching care of doctors from one in Penn to one at Johns Hopkins, and she basically had to get the pile of paperwork that you had said
No.
um, is kind of an option that hospitals don't like to use. But that was basically care from 1992
Mhm.
to 2020. Do EHR portals, do they currently have anything that's a certain amount of history digitized, or if it's prior to that act, as everything just needs to be paper?
So excellent question. By the act, hospitals were not required to make records available in the portal the same way they did others. And depending on what EHR you have, things like that, there are limitations on it. At St. Jude, we were on Cerner until 2022 and then switched to Epic. And so some of our Cerner data, about 3 years of it, got transferred over into Epic, and that is available for patients in their portal. Um, the anything before those previous 3 years is in an archive. I
Hmm.
have the ability to go into the archive as a St. Jude physician and look and find all this data, but it is not easily searchable. And so usually for that older data, that involves a call to HIMSS and things like that.
Hmm.
What the 21st Century Cures Act does say is that even if you're asking for those historic records that aren't in the portal, the hospital still is required to provide those to you. And this gets into the without delay.
Hmm.
If it
Hmm.
is something that, involves them going into databases and downloading or printing, a whole lot of information or scanning old paper records, there is some obvious delay that will happen. It can't be instantaneous. Um, and so it will be there. The other part to your question, it wasn't directly to your question, but when you were stating it, is the having, a patient having to collect data to share with another doctor. That is very often the easiest way to do it. Um, Obviously, patients, you can sign medical release forms that say, please send all my records to this other clinic or to this doctor, and HIMSS can usually do that directly. Um, Another part of this is that if I am seeing a patient who was treated by a doctor at another hospital, I can reach out to that hospital, and as a treating physician, I can request those records.
Hmm.
And HIPAA does not block that sharing. So physician to physician transfer information for the continuing care of a patient is actually one of the parts that HIPAA promotes that, is that it's like, okay, no, that should
Yeah.
be, a hospital shouldn't be able to say, no, you can't have this data, this is ours.
Hmm.
That data belongs to the patient, and if I need it to treat that same patient, I should be able to access it without hurdles. Um, oh, there was one other point I was going to make about, oh, I think that probably was enough. But any other questions? I'm happy to spend time answering.
Yeah. If any other questions come in as I'm wrapping up,
Okay.
I'll pop it over to you. I just wanted to start wrapping up and just remind people of some of the Histiocytosis Association's resources. On our website, we have disease information, educational videos, uh, as well as the archive of our previous webinars, uh, information on grants that we've funded and research initiatives that we've been a part of or started. Um, an international physicians directory, which is searchable, and you could search by country, disease, age. Uh, Maybe the student scholarship program, which is actually currently open, still accepting applications until the 27th of this month. We have awareness two accounts that you could have sent to you. We have peer-to-peer connection calls, one's for patients, one's for caregivers, one for grieving family members. You can find all these things at histio.org, which is linked right there. We also have the community forum, which has links on the right, and you could scan the QR code to go onto Facebook and explore the community forum as well as our social media pages. And here's just the contact information for myself and for uh, the host from today. I just want to add special thanks to Sarah Hastings from St. Jude, who helped to connect me with Dr. Campbell and uh, to plan this with him as well.